Welcome to the Jerry Pal podcast. This is Eric Woodera.
This is Alex Smith.
And Alex, who do we have with us today in studio?
In studio, visiting professor coming to us from Boston. She is a returning Jerry Pal guest. This is Sarah Berry, who is at the Hebrew SeniorLife and Beth Israel Deaconess Medical Center and Harvard Medical School, and she's a practicing geriatrician and researcher. Sarah, welcome back to the Jerry Pal podcast.
Thanks so much. Happy to be here.
So we're going to be talking about falls and fractures. We got a lot to talk about. I got a lot of questions, but before we do, Sarah, do you have a song request for Alex?
Ooh, how about Free Fallin'?
Free Fallin'.
I'm going to ask why you chose this song.
We did this like in one of our first podcasts, I remember. And the second verse, I kind of went for it.
Yeah.
But today I'm not, because it is November 6th. And I'm feeling subdued.
We won't talk about what happened on November 5th.
So here's a little bit of subdued Free Fallin'. She's a good girl, loves her mama, loves Jesus and America too. She's a good girl, crazy about Elvis, loves horses and her boyfriend too. It's a long day living in Reseda. There's a freeway running through the yard. I'm a bad boy, 'cause I don't even miss her. I'm a bad boy for breaking her heart. And I'm free. Free falling. Said I'm free. Free falling.
Sarah, excellent song.
That was nice.
Choice. Is there any other reason you picked that song besides? Are you a Tom Petty fan?
I am a Tom Petty fan.
Yeah?
But it was just the first thing that came to mind when you asked me to talk about falls.
Well, I want to thank you for joining us, because you've done a lot of the studies around falls and fractures and like how we think about it, especially like in frailer, older adults, those in nursing homes. I wonder, how did you get interested in this as like a research academic focus of yours?
Yeah. When I went into my geriatric fellowship, or even during residency, I think that I thought that I was going to be interested in dementia, and that maybe that would be my line of focus. But I was really struck early on in my training by the number of patients that had these serious falls, fractures, sort of this feeling that they were never going to get back home, or they weren't going to get back home in the same shape that they were before. And I had a good mentor in residency that really encouraged me, if you want to think about the problem, think about clinical research, and was really fortunate to have great mentorship throughout my career.
Great. And when you think about like back then, I guess now too, like how big of a problem is falls?
Yeah, it's a pretty big problem for older adults. I'd say in community dwellers, about 1 out of every 3 older adults falls each year. In the nursing home, that's higher. It's 1 out of 2.
Wow.
I think the CDC estimates that every 20 minutes, an older adult dies from a fall-related injury.
Wow.
And many more are injured.
Yeah. And the big things that we think about as far as complications, so there obviously the thing that comes to everybody's mind is like fractures, but there's other things too, right? Like increased social isolation because there's a fear of falling. Is that right?
Yeah, absolutely. Even the falls that don't result in a major injury, like the fracture, the head traumas, even the falls without those tend to result in an increase in fear of falling, anxiety, and institutionalization.
Yeah. And, I wonder how much, because it's probably not brought up a lot in primary care settings, people don't ask about it. They don't screen about it. I'm guessing older adults don't bring it up frequently that they've fallen. So that it's just a silent, I don't want to say silent epidemic that's used too often, but there's silence around these falls. And there's probably some nihilism about kind of, what can we do about falls anyways?
No, I think all of that is true. I think there's just sort of this feeling that maybe it's inevitable because it happens so often. I think both the patients feel that. I think providers feel that way, right? You see this in people's notes.
Yeah.
It was a mechanical fall, and people kind of stop getting curious about why it happened or how they can prevent it.
So is nihilism the right approach here? Like, there's nothing we can do. Or do you feel like, and we can talk about if so, there are things that we can do to prevent falls and prevent the complications of those falls?
Yeah, there are absolutely things we can do to prevent falls and prevent the complications. Maybe not all falls, but we can certainly reduce the frequency of falls and reduce serious injuries in the setting of a fall.
All right, before we get to that, I got some other important questions. Interrupt me anytime, Alex, if you got something.
Okay.
So if I were to believe you that we're going to get to like what interventions we can do to decrease risk for falls, how does Sarah screen? Do you just ask people like, have you had a fall lately? How do you screen or assess for risk for falls?
Yeah, that's honestly the best way to screen for falls is, have you had a fall in the past year, or are you worried about falling? Mm-hmm. And if the answer is yes, then the patient's at risk.
Yeah, that's like one of the biggest risk factors. Is that right?
Absolutely.
Any other risk factors that we should be worried about?
Well, there's lots of risk factors for falls. Some of the major ones, things like dementia, cognitive impairment, Parkinson's disease, abnormalities with gait, balance, frailty, low, high body mass index. I mean, there's a lot, medications. It goes on and on.
Yeah.
But I do think consistently across studies, across settings, sort of the number one predictor of falls is, have you had a fall in the past year?
Mm-hmm.
So if there's one question our audience should ask,
absolutely,
older adults, have you had a fall in the last year?
Or are you worried about falling?
Yeah.
Are there professional society recommendations or U.S. Preventive Services Task Force recommendations to screen certain groups, all older adults, for falls?
Yeah, the CDC has nice recommendations, the STEADY guidelines, and honestly, it follows pretty close with the American Geriatrics, British Geriatric Society guidelines for screening for falls. But really, they recommend that annually that you ask adults 65 years and older if you've had a fall or if you're worried about falling.
Okay. You have somebody who says, yes, I have fallen. Alex, I know Alex has fallen. He's broken it. In the last year? You're on a bike.
I'm always,
count?
I don't know if that counts. Fall from bike.
Okay. Actually, the last bike accident, you didn't even fall. You stayed on the bike.
It broke my hand while on the bike.
Okay. You have somebody who's screened positive. What do you do? What's the next step?
Yeah, so it's probably assessing their gait and balance is the next step. So, in community dwellers, I'd do the get up and go test. Ask them to stand, ideally without using their arms, walk about 10 feet, turn around, sit down. And they should be able to do that if you're timing them in 12 to 15 seconds or less. If you don't have the capabilities or, to do a timed up and go test, don't let perfect get in the way of good. Just have them do that test and see if you're not worried, you're a little bit worried, or you're a lot worried. If you're a lot worried, you've got your answer. If you're a little bit worried or unsure, then maybe you move on to another test of balance.
Mm-hmm. So again, at this point, you're trying to assess for risk for falls using the timed up and go. Are you also doing an assessment, like Sarah's doing a timed up and go? Like, are you actually watching their gait and thinking about what do I think I can maybe intervene on?
I do. I pay attention to arm swing is a big one. You pay attention to their assisted device and how comfortable that feels with them, how stable that feels with them. But, honestly, even just a gut gestalt, I'm a little worried about this patient. I'm not worried about this patient at all. I think it's better than nothing when screening patients for gait.
Great. And so you're getting the sense now you're worried that this patient's moderate to high risk. Timed up and go was long.
What's long?
More than 12 or 15 seconds.
More than 12 or 15 seconds.
What does Sarah do next?
Yeah. So, again, if you're really worried, you've probably got your answer.
Yeah.
And in somebody who's had a fall and they've got gait abnormalities, they probably need to talk with them about falls and about, sort of multifactorial interventions, targeting their greatest risk factors to reduce the risk of falls. If there's somewhere in between, where you're a little worried or you're unsure, you might do a balance test. So that is asking them to stand with their feet together, for 10 seconds, and then the semi-tandem stance where one foot is halfway in front of the other, and then the full tandem stance, one foot in front of the other for 10 seconds. And if they have trouble with that, then again, I would consider them high risk and move on to this multifactorial intervention.
And tell me, what is a multifactorial intervention?
So, it's really assessing patients, for their individual risk factors for falls. So gait is one we've already talked about. Vision is another obvious one. Hearing is one. Looking at medications, I think, is a really big one and highly modifiable. Orthostatic vital signs, I think, can be appropriate. Just a good footwear, maybe another one, again, that's highly modifiable. But just looking at sort of their risk factors and trying to target those that you can intervene on.
So potentially like some of these intrinsic issues, including kind of their vision, are they having orthostasis? Is that why they're falling? Do they have some other medical condition like Parkinson's disease that may be contributing to it? Yep. Medications, which medications are you most worried about?
Yeah. Medications in general have been shown to increase the risk of falls. So persons that are taking more than 5, 7, there's been a number of different thresholds that have been proposed, sort of irregardless of what medication it is.
So just the sheer number.
Yeah, just the sheer number. But certainly psychotropic medications, and there's really no evidence when it comes to falls that some of the newer psychotropic medications are any safer than the older ones, right? We might choose a newer antipsychotic over an older antipsychotic because it has less of the motor side effects, but we really shouldn't kid ourselves into thinking that it's safer when it comes to falls.
So antipsychotics, benzos, I'm guessing on there, all the sleep medicines potentially on there. Correct.
Gabapentin's another one that I'm concerned about. I think there's a few studies in dialysis patients and in hospitalized patients, suggesting that gabapentin and pregabalin is associated with an increased risk of falls.
Yeah.
How about opioids?
Yeah, that's another one. And it's tough, right? Because, the pain, you're often giving these, medications to patients, there's some intractable confounding there. Nonetheless, they probably do increase the risk of falls.
Mm-hmm.
Yeah.
And marijuana or Marinol or cannabinoids?
Yeah, great question. I don't think we've got really solid data on that. And I think in particular, there's interest sometimes in the nursing home in using that in place of other drugs. And I think it's something we need more data on.
Came up on our recent podcast about update on cannabis and marijuana. And one of our guests mentioned that you can use cannabis products for treatment of behavioral symptoms in people with dementia in nursing homes, which was news to us. So interested about the potential side effects of that.
Yeah, my suspicion is it's like a lot of these others, like gabapentin, that it maybe, have a better profile for other things, but perhaps when it comes to falls, it's no better.
Yeah. Anything that's potentially somewhat sedating.
Correct.
Mm-hmm.
Yeah.
How do you think about blood pressure medicines?
Right.
Yeah, that's a great question too. The studies are mixed, where some studies suggesting that blood pressure medicines are associated with an increased risk of falls. Some studies even saying that maybe they're associated with a decreased risk of falls. There was some work from Mary Tinetti's group, looking at a large sample of hospitalized patients with injurious falls and their antihypertensive use. And really, what I took away from that study was it matters whether you have a history of falls. So they did a subgroup analysis, and in particular in adults who had reported a fall in the past year, they seemed to be at greater risk of injurious falls with antihypertensives.
Mm-hmm.
So again, going back to that, if you just have one question to ask your patients, or when you're thinking about what that blood pressure target should be, maybe it's if I've had a fall in the past year.
Mm-hmm. Did you do a study where you looked at the falls around the time of initiation of antihypertensives?
Yeah. Great memory. It's been a little while, but we looked at a number of classes of medications and found that when you increase the dose or start the medication, patients were at a particularly high risk of falls. And that's true not only for antihypertensives, but for the diuretics. It was true for meds like benzos, antipsychotics, and for antidepressants. And that included the most common antidepressant in that study was trazodone, something that we sort of, typically consider to be a safer geriatric drug.
Okay, I got another. My last falls meds question doesn't increase risk for falls, but may increase risk for complications of falls. How do you think about anticoagulants in falls, specifically DOACs?
Ooh. Yes, I think that's also an area where we could probably use some more research. We looked at it in nursing home residents, and we looked at sort of standard dosing of DOACs. So that would be like for apixaban, the 5 milligrams BID versus anything lower than that we called reduced dose of DOACs. And we found that, at least in nursing home residents, there was no difference in the efficacy of the drugs when you got the lower dose, but there was certainly an increased risk of bleeding. And a lot of this is, as you say, it's bleeding in the setting of, some of this is bleeding, and some of this is bleeding in the setting of a fall.
Okay, so we have these intrinsic issues, but there's also like extrinsic issues that contribute to falls, including in people's homes.
Yeah.
How do you think about that as you're seeing patients, or potentially in nursing homes? Like, you also work in a nursing home, is that right?
Yeah, I work in long-term care and asked to see a lot of fallers.
How do you think about those extrinsic factors?
Yeah, I love it that you asked those questions because I think that that's something that we don't often think about. I go back to at the beginning of the podcast, I mentioned, there's this tendency you'll see in the chart, it was a mechanical fall, and people just stop. But if you ask people, people have these chronic risk factors that you mentioned, the Parkinson's disease, the cognitive impairment, the visual impairment. They have them every day. But there's generally some trigger, something that happened that they fell last Tuesday, right? And you've got to really ask about the situational factors to learn about those. So, it could be things like, the throw rugs people talk about, or poor lighting. You mentioned, starting a new medication, I think is sort of falls into that area as well. Risk takers is another thing. The people that, are climbing up on ladders or on washing machines to get things down, they may not volunteer that information, but, if you ask them kind of what was happening with the fall, you may be surprised and learn.
Yeah. And if I remember correctly, I think there was one, was it from BMJ or I think it was a UK study. They looked at eyesight. They saw like ophthalmologists, a bunch of people got glasses. And what happened is there was an increased risk for falls. And I think it turned out the most common prescription was like a bifocal lens.
Yeah, I think you're right. So cataract removal, first cataract has been shown to reduce the risk of falls. But you're right. I mean, I think giving people proper eyewear is good care, but hasn't necessarily proved to be effective, or at least by itself in reducing falls.
And I think the interesting thing about bifocals, if you look straight, everything's in focus. You look down, now you're using your reading glasses basically, so you're not seeing any of those. Yeah. Those things that could potentially make you slip, fall.
Right.
Okay. What are the evidence-based interventions that we could do to reduce falls?
Yeah. So in the community dwellers, I would say the strongest evidence base is for exercise, right? So it needs to be exercise that includes some gait balance and strengthening. It's been shown to be effective when done in groups. It's been shown to be effective when you give patients home exercise. I mean, exercise, I think there's no question, is effective in preventing falls and fall-related injuries. Getting people to exercise, right? Now that's the challenge.
Mm-hmm. Is Tai Chi part of that? I see a lot of Tai Chi falls articles out there.
Yeah, Tai Chi is one type of exercise that certainly combines some strengthening, core strengthening, and balance. So it's nice. And yes, there's good evidence in community dwellers that Tai Chi prevents falls.
All right. How about in nursing home or long-term care settings?
Yeah, nursing homes, it is a little bit more complicated. The evidence that exercise prevents falls, or particularly that it prevents falls in persons with dementia, which is the majority of nursing home residents, I think it's a little less clear. Mm-hmm. What seems to be effective in nursing homes is, again, doing a an assessment of all the patient's risk factors, right, and then honing in on the ones that are modifiable and trying to address them. That's certainly what I do in the nursing home. I often find, again, you're looking and asked to see somebody after a fall and they're wearing slippers, without a back and no tread, right? Again, we may not prevent all of the falls that person has, but we can reduce the number of falls by targeting risk factors like that.
Mm-hmm.
What if there was a simple vitamin everybody could take that would reduce their risk for falls? Vitamin, let's call it D. Vitamin D. I love vitamins because we get really into them until we realize that they don't really work. Where are we in that cycle with vitamin D? There was a lot of talk about vitamin D about a decade ago, decreasing falls and fractures. Did that hold up?
Yeah, you're right. The pendulum really swung pro vitamin D, then it kind of swung the other way. And you've got these meta-analysis, maybe more meta-analysis sometimes than individual studies
I think they have
on vitamin D, and often with conflicting results, right? So it's hard. What's a clinician supposed to do? Right. I think some of the uncertainty and the discrepancies in the meta-analysis depends on which patient population you're enrolling. And in general, I would say that the evidence does not support that vitamin D prevents falls for your average, community dweller, persons that are probably replete with vitamin D. But in nursing home residents, there is actually evidence that vitamin D reduces falls, and in particular that calcium and vitamin D can prevent fractures in nursing home residents.
And for those studies, didn't matter what your vitamin D level, or did everybody have low vitamin D level?
Yeah, it didn't matter in those studies. So they were, randomized trials. And one, they didn't check the vitamin D level, and the other they did, but it was fairly comparable across the groups.
So nursing home, long-term care, vitamin D prevents not just falls, but fractures. And it's interesting to try to think what's the mechanism by which vitamin D and calcium might prevent falls. The fracture part I can get, but mechanistically, the fall part I have trouble with.
Yeah, I am certainly not an expert on this. There's been a lot of, speculation. There are vitamin D receptors with muscles, the way that it's metabolized with the kidneys. I think there's a lot of speculation, but I also think there's a lot of unknowns.
Yeah, in some ways it's a hormone too, because they've also done studies on vitamin D really high levels, which actually shows a higher risk for falls.
U-shape.
Yeah. So, right, there is this recommended, for most people, it's, get it through your diet in sufficient quantities. But for the people that you are going to supplement, you don't want to give too much and you don't want to give too little. Is that right?
Correct. And it's one time in nursing homes, it's so tempting, I think, to give the higher doses just to reduce the pill burden, which is real and problematic in the nursing home. But I do think it's one area where we have pretty strong evidence that the higher doses of 50,000 international units, for whatever reason, does seem to be associated with an increased risk of falls.
What does Sarah Barry do? 800? Is that your target? 800 international units?
Whatever's available, 800 or 1,000.
Yeah.
Maybe if I'm particularly worried about somebody and they have some risk factors, they're obese, dark skin, maybe I'd go with 2,000.
I know we want to get to the fractures part, and I have two more questions from my perspective about the falls part. All right, so in the long-term care setting or the hospital setting, our first podcast was about bed alarms.
Bed
That
alarms.
was the first GeriPal podcast.
Yeah.
So there's this tension, right, between safety and fall risk and autonomy and allowing people to take risks. And
if you just restrain them in bed, Alex, they won't fall.
Right, you will reduce your, maybe. You'd think that it would reduce the fall risk. I don't know whether it actually does. But how do you think about that tension in the long-term care setting?
Yeah, that's a great question. I'm definitely a believer that fall rates, we can improve them in nursing homes, but they cannot and should not be zero, right? If we've really suppressed them that far, then we probably are restraining people too much. It is a challenge. I'm delighted our facility made the decision years ago to be alarm-free.
Oh, really? No bed alarms?
No bed alarms.
No bed alarms.
And we did it was relatively crude, but analysis looking at rates of falls before and after the bed alarms and didn't find any difference. And again, it made the nurses happy to get rid of them. They were responding to to these false alarms that were going off, particularly in our really thin patients. And also, I'm not sure that they were really preventing falls, right? You were just finding the fall after it occurred.
Because it is interesting, because like you said, one of the most important interventions is exercise, mobility, like moving around, which also increases your risk for falls potentially because you're moving around. But in the long term, it may decrease your risk. But bed alarms is like the opposite. It nudges people never to get out of their bed or their chair that the alarm is on, because you're going to have this really annoying sound.
Yeah, I think you said that well.
Yeah. Mm-hmm.
And the nurses, they drive them crazy.
Okay, my second question is, in the outpatient setting, we had a podcast with Tom Gill about that STRIDE study published in New England Journal, and my general recollection, not having reviewed it recently, is that it was a multi-component intervention and that the primary outcome was prevention of injurious falls, and that was not a significant difference, and that it did, in a secondary outcome, prevent falls in general. Any thoughts about that study in the outpatient setting and whether that affected your practice?
Yeah, that's great. And I think it was discouraging for a lot of us that believe in falls prevention strategies. In the way that I interpret it, I'm still a big believer in falls prevention strategies. What was different about that trial and some of the individual trials that used exercise or visual changes, right, is that this was a pragmatic trial, right? People didn't sign consent. They didn't say like, hey, I'm looking to prevent falls, right? They took primary care practices and they randomized them to get their prevention. So instead of in the trials, right, you've got a highly motivated group that wants to wants to prevent falls, whereas in the pragmatic studies, you don't. And again, I don't see that as that falls prevention doesn't work. I think it's just a reminder for us as physicians that you can't give somebody a multimodal intervention just because they're at risk of falls. You've got to talk to your patients about falls and see where they are. We talk a lot about with smoking cessation or weight loss, right? About readiness and sort of patient activation, right? If you've got a patient and they may have a lot of risk factors for falls, right? And they may have even had a fall with a bad injury. But if they're in this pre-contemplative stage and they tell you that, I'm never going to fall again, it was just a silly mistake, don't worry about me, right? Trying to give them, a multifactorial intervention and a lot, right? It's not going to work, right? Mm-hmm. We need to instead talk to the patients about how serious these falls are, move them from a pre-contemplative state into a state of action, and then just, give them one intervention at a time along the way. Mm-hmm. And, to me, that was the difference between, it's not that the stride approach was wrong, but to me, that's why they didn't find an effect.
Mm-hmm. Okay. So we have the falls. We're doing everything that we can do to reduce the risk of falls, but we also should think about how do we reduce the risk of the complications of falls, in particular fractures. How do you assess for the risk of fractures, especially like in your population, nursing home patients or frail older adults or older adults with multimorbidity? Like these people are not part of clinical studies generally. How do you think about that?
Yeah. I think in general, probably bone mineral density screening isn't going to fully capture risk in sort of your frail older population. So if you have it, great. I'm not discouraging or saying there's not value in that, but really considering their clinical characteristics. So, in the community, probably the best studied model is the FRAX model, which is available. It works up to age 90. Beyond age 90, they didn't have data, and so you're sort of on your own, or just sort of assume the age of 90.
And is that just postmenopausal women or men too?
No, the FRAX works in men too, and you can calculate it with or without bone mineral density. And honestly, it does pretty well even without bone mineral density. And so that's often what I would recommend in community dwellers that are a little bit more frail. Maybe you've got a bone mineral density test. Maybe it's 5 years old, 10 years, an older test. Still put it in. Put in what you have, right? And get kind of a risk. And then I kind of take that risk, and it's like, anything in geriatric medicine, there's a little bit of interpretation with it. I think if you have somebody and they're kind of on the fence, right? But they've also got Parkinson's disease and cognitive impairment, and they're on a number of medications that make you nervous, round up and assume that their risk is a little higher than it is. Conversely, if you've got a patient and they're bedbound and immobile and or more near the end of their life, right, you might round that risk down. And I recognize that that's not highly scientific, but I think it's just sort of kind of what we have for frail older adults in the community.
And we'll include a link to the FRAX model in the show notes associated with this podcast. And just for our listeners, though, it's spelled FRAX.
Correct.
Is that right? Yeah.
Correct.
Okay, what about in a nursing home setting? Does FRAX apply, or are there better ones?
Yeah, I would say FRAX is probably not the one to use in nursing homes because, again, FRAX gives you a 10-year risk.
Yeah. And,
calculating a 10-year risk, and I recognize that it takes into account the competing risk of death. It also doesn't consider a lot of, the characteristics of nursing home residents. So we've developed a model. It's called the FRAIL model, the fracture risk assessment in long-term care, that predicts the 2-year absolute risk of hip fracture. We've got a website. It's not nearly as pretty as the FRAX website, but you can put in the patient characteristics and get a 2-year risk of fracture. I would say short of the website, though, and sort of an absolute tool, the real drivers in the nursing home tend to be patients having a history of falls, right? Having a history of fractures. and patients' mobility or independence, right? So the patients that are independent in their activities of daily living and they're independent in transferring, those patients are at highest risk of falls in the nursing home. And then as residents become more dependent, their risk actually goes down. So it's a little different, right, than in the community dwellers where we usually think of impairment increasing the risk.
Yeah. Kind of also that U-shaped curve. So like somebody with advanced dementia who is now bedbound, their risk for having a fall is
correct.
A lot lower.
A lot lower.
Then the question is there a role for potential medications to help reduce that risk for fractures? So, the ones that we think about like bisphosphonates, how do you think about bisphosphonates and reducing that risk?
Yeah, so are we back in the community or nursing home?
Yeah, let's go back to the community briefly. Then we'll focus probably most of our energy on this frail, older, multimorbid.
Yeah. Well, I would say even in community dwellers, there's good evidence that bisphosphonates reduce the risk of fracture. The time to benefit...
For men too?
For men too.
Yeah.
And probably the time to benefit is about 13 months, a little over a year. So in general, my rule of thumb has been if I think somebody has about a 2-year life expectancy, then it probably makes sense to at least consider these drugs, right? It may not be consistent with their goals of care. It may not be appropriate, but at least to consider them, right? Somebody that's got a life expectancy, I think they're probably going to pass away in the next 2 years. I probably wouldn't. But I would say that there's, post hoc analysis of randomized controlled trials in patients with hip fracture, men and women, that got zoledronic acid versus not. And they looked in a subgroup analysis of those with cognitive impairment. And it didn't look like the fracture benefit was really much, it still reduced fractures in people with cognitive impairment. We've also done a large observational study where we looked at patients who are hospitalized with a fracture, and then to see who got a bisphosphonate after or not. And we did subgroup analysis. People were either frail at the time of their fracture or not, using the frailty index. And again, it looked like the bisphosphonates, that the beneficial effect was pretty similar. So I think we actually do have growing evidence that the bisphosphonates are reasonably effective even in patients with cognitive impairment. Yeah. And with frailty.
Mm-hmm. And for more on that, also consider listening to our prior podcast with James Deerdorf and Say Lee about the lag time to benefit for bisphosphonates. I remember them saying they were surprised when the lag time to benefit was 13 months. So, it was about a year.
Well, let's ask about that. So in James Deerdorf's study, we'll have a link to it in the show notes. I have it written down here because I looked it up. Mm-hmm. 10 RCTs, they combined nearly 23,000 patients included in these 10 RCTs. All were women with osteoporosis. Yeah, women with osteoporosis. The lag time to benefit. So it took 12 months to avoid one non-vertebral fracture per 100 women. And to avoid one hip fracture, the number needed to treat was 200 at 20 months. So nearly 2 years. Mm-hmm. Does that ring true to you?
Yeah, that seems reasonable. Yeah. And again, I think we have that meta-analysis was focused on the clinical trials that, as you say, they were postmenopausal women. They weren't necessarily frail. They weren't the patients that we were taking care of, and they weren't men. That being said, I think increased observational data supports that the benefits of the drugs are probably similar, in subgroups. So, if somebody has, I would say a 2-year life expectancy is sort of what I have in my mind as sort of, for these drugs.
And why 2 year? What's
why not one? Because on e-prognosis, I think we put it at 13 months or 1 year or something like that.
Which is interesting because that's also for any non-vertebral fracture. And again, hip fracture obviously is longer than that. It's closer to 2 years.
Yeah, I mean,
and the number to treat is 200. Got to 200.
Maybe we should move the needle on the.
How do you think about
needle? That reminds me of last night. Okay, wait, back to now, the present.
The present.
Present.
2 years versus 1 year, Sarah. Why are you thinking more 2?
Hard to pin me down. So I think, as you said, sort of 13 months, right? So somebody's got to live 13 months before they get a benefit in any fracture. And then hip fractures, which are the more serious ones, are about 2 years. So, I mean, and let's be honest, I mean, I'm not sure that our prognosis tools are so fine that we can release, but if I would not be surprised that somebody passed away in the next 2 years, then I probably wouldn't be using them. But otherwise, I think we should at least have a conversation and consider.
Yeah, I love this because I was reading one of your articles I have a link to. It was controversies in nursing homes about falls and fractures and osteoporosis meds. And one of the things was not just when to consider starting it and incorporating some of these things that you're talking about, like life expectancy. Are they bedbound? Like, are they getting up and walking around? Those types of things. But also, when do we stop these drugs? And importantly, we think about this all the time, like in our hospice unit. Should we continue these medications or should we stop? How do you think about stopping these medicines?
Yeah, it's tough. But the good thing we know about the bisphosphonates is they have this very long half-life, right? There are randomized control trials, the FLEX trials, where they looked at women who had taken alendronate for 5 years and then randomized them to continue versus stop. And in general, there was not a lot of difference in fractures in those that got the 5 years versus those. And so we know, too, that these drugs are associated with a rare but serious risk of atypical femur fractures that almost never happens until you've been on them until 5 years or more. And so, yes, so for all of those reasons, it makes sense to consider, a drug holiday or stopping. I think in my patients, if somebody's been treated for 5 years and they're within the last few years of their life, right? You're probably talking about stopping the drug. It's not a drug holiday. There's no need to do additional screening or consideration, right? Similarly, I think, patients who have been treated and they're, as you said, they're no longer at risk or not at the same risk of falls, right? They've become not ambulatory. They're more sedentary. They're, or bedbound requiring a lift, right? That's probably another time when, if somebody's been treated, it makes sense to stop. And then I guess can become a little gray, right, is, somebody's been treated 3 years or somebody's been, a little bit less. And in general, I do try to think, if somebody's not ambulatory and I think their life expectancy is 2 years or less, it is probably appropriate to stop bisphosphonates.
Can I ask how you have that conversation? Like, what do you say to patients or their family members?
Yeah, I think sort of reminding them that this drug is still in your system, that you're probably still benefiting from this drug. But if you were to continue taking this drug, it might have some adverse, side effects, right? And that your risk is not the same as it was before. That is a tough conversation. Yeah. Just to mention, because I think sometimes it's confusing, this recommendation is really specific for the bisphosphonates. Denosumab is a little different.
How so?
Yeah, so denosumab is a drug that it works by blocking the osteoclast activity. And as soon as you take the drug away, there's this increased activation of osteoclast. You break down bone. And there's an increased risk of vertebral fractures in particular and probably other fractures. So denosumab, the good news is it's only given every 6 months. But in general, but the notion of holidays, right, don't apply to it. It's a short-acting drug. I still think it's reasonable to stop it if you think that somebody's life expectancy, if you think they're within the last year of life, again, or they've become really immobile.
Okay, I got last question for you, unless Alex has another question.
Well, can I ask mine first so that I can put on my guitar? Yeah. Returning to the outpatient setting, or maybe inpatient or long-term care setting as well. Exercise, we talked about for falls. For fractures, specific types of exercise that you encourage your patients
like fracture
to
prevention?
Engage in to prevent fractures, improve bone health. Is
tough question. Do you know?
I don't know. I think of like weight bearing. Like, isn't the mantra you got to grind the bones?
Yes. So, I mean, definitely weight-bearing exercise is best for the bones. So something like swimming, for instance, is great cardiovascular, but doesn't, doesn't stimulate bones. But I do think there's a lot of uncertainty for our more frail older patients, particularly those who've had vertebral fractures. They have a lot of kyphosis of like exactly what types of exercises, strength and conditioning we should be recommending for them. So love to get PT's input on that. And yeah, thanks.
Sarah, last question for me. If you had a magic wand, you can make one thing different around how we either screen, assess, or treat falls and fractures for our listeners. What would that be?
I'd like physicians, particularly young physicians, to get curious about falls. I think they're just so common in older adults that we sort of lost our curiosity. But if you're curious and you ask about them, you can prevent them. Not all of them, but some.
Love it. Alex, a little bit more free falling, Tom Petty?
What a treat.
I want to glide down over Mulholland, want to ride her name in the sky, gonna free fall out into nothing, gonna leave this world for a while, and I'm free. Free falling. Said I'm free, free falling.
Sarah, thank you very much. If there was a song that could capture the mood that I'm in on on November 6th, that is a song. So thank you for that. And thank you to all of our listeners for your continued support.
Thank you. That was fun.
We'd also like to say a very big thank you to the donors who've donated more than $250 in the last year to support the Jerry Pal podcast, including
Asher Edwards, Jerry Gerwitz, Victoria Brond, Meg Walhagen and William Strawbridge, Jessica McFarland, James Tulsky, Susan Nelson, Sharon Brangman, Daryl Lowens, Craig China, Mike Steinman and Dorothy Richmond, Diane Meyer, Matt Schuster, Harry Hahn, Elizabeth Chung, Wendy Peltier, Kelly Strait, Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, and Stuart Oserman.
Thank you very much.